during presentation. And so today we are having two speakers with us, and our one program is going to be on kangaroo mother care. So we just celebrated Kangaroo Mother Care Day on the 15th of May. So we thought that this will be a nice occasion to have a lecture on kangaroo mother care and to improve the awareness of skin to skin contact and the immense benefits. So we have arranged one topic for kangaroo mother care. So we have a registered nurse. This is Rekha Samant with us, and who is from KEM, and she'll be here to be talking about kangaroo mother care. Then our second talk is going to be on skin care of newborns. So which will be delivered by Dr. Rahul Kulkarni, who has done fellowship in neonatology, and he's an experienced neonatologist and pediatrician working in Pune. So I'll quickly introduce our experts today. So today we have renowned neonatologist and teacher for all of us, Dr. Ruchi Nanavati madam, who does not need any introduction, but we are happy that she is gracing this program, and will be giving her expert tips and guidance throughout this program. Our second expert for today is Dr. Sagar Lad, so who is also a neonatologist who is currently practicing at Jahangir Apollo Hospital, Pune. So he's a senior pediatric intensivist and neonatologist. So he has several publications to his name and has won several awards. He's also a postgraduate teacher for IIPPSU fellowship programs and has contributed to an article in Cochrane Protocol. So we have invited him as one of the experts today for this session. So if Dr. Sagar Lad has joined, I'll ask him to quickly introduce the speakers, and so that we can begin with the program. So Dr. Sagar Lad, are you there? I think he's cannot hear him. Dr. Sagar Lad, are you there? Can you hear us? Okay, so I think he has not joined. So we'll begin our today's session, probably joining in some time. So we'll begin our session with Dr. Rahul Kulkarni. So he'll be presenting skin care in neonates today. So he has done his fellowship in neonatology NNF from Pune Sant Gnaneshwar Medical Education and Research Center. And he has got 8 years of experience in neonatology and is currently practicing as a pediatrician and neonatologist at Asta Children's Clinic and Siddhivinayak Hospital, Pune. So I welcome Dr. Rahul Kulkarni for his talk on skin care and what every neonatologist must know. So Dr. Rahul Kulkarni, you can start with your talk. Thank you.
Okay, thank you. I'm audible, sir, properly?
Yes, yes.
And I'm visible. Yeah. Sir, actually some thunderstorms are going there in Pune right now, in capitals. So there might be some possibility of internet issues. So
yes,
please obligate me that. I'll share my screen and so is it visible properly?
Yes, yes. You can share your screen. We cannot see your screen.
Share.
Yeah, click on the share screen button. Green.
Yes, sir. Actually, I have already. Is it visible, sir?
No, I cannot see it.
Yeah, just a minute, sir.
Yes, now I think, yes, now we can see. You can run the slideshow.
Yes, sir. So what we are going to see today is the skin care of a neonate. what every nurse must know. थोड़ा थोड़ा मैं बीच बीच में हिंदी में भी बात करूंगा, so that सबको ये चीज ठीक से समझ आ जाए. First of all, first thing, what is important in a skin care of a newborn? तो पहले हमें सबसे जरूरी ये मालूम होना चाहिए कि इतना जरूरी क्यों है न्यूबॉर्न का स्किन मालूम होना. तो न्यूबॉर्न की जो स्किन है इट्स वेरी डेलिकेट. जनरली हमारे एडल्ट्स की जो स्किन होती है उससे 10 टाइम्स ज्यादा वो डेलिकेट होती है. सो नाउ इट्स माय ग्रेट प्लेजर कि आप सबके सामने मुझे बोलने का मौका मिल रहा है. आई फील रियली ऑब्लिज्ड और I am very thankful to SCNNF for that. So our first salary, when a person decides to become a nurse, they make a most important decision of their life because they choose to dedicate themselves to care of others. So सब यहाँ पे आए हुए सब नर्स सिस्टर्स को मैं नमन करता हूँ क्योंकि most of the things we learn from our sisters in our residency, and we will really appreciate their efforts, and they are really the backbone of our NFU. So what's our today's topic is skin care of a neonate or a newborn in an NFU. So in a neonatal care and infant, what we are going to see is the introduction, the aim, definition, how to assess, and different managements of the skin. So first of all, skin acts as an interface between internal milieu, means internal environment, and external environment, and it provides many functions for the human survival. What are the functions? First function is maintenance. Second is the thermoregulation. Third is the minimization of the caloric loss. Then antimicrobial defense, along with protection from the toxins, trauma, and ultraviolet radiations. Of course, tactile sensation is most important part of that. Preservation of skin integrity, reduction of the skin factors, and neonate skincare education for the parents are the key nursing priorities in the care of a term and a preterm neonates. Skin contains 3 separate layers. The uppermost layer is called a stratum corneum. This provides the barrier function of a skin and has 10 to 20 layers in adults and term neonates. It protects against toxins, irritants, allergens, and pathogens, and retains heat and water, as well as maintaining a normal microbiome of a human skin. During the first year of the life, stratum corneum is not fully mature and is approximately 30% thinner than that of the adult skin. Directly under the stratum corneum is the basal layer of the epidermis and then the dermis, which are the thinner and underdeveloped in the neonates compared to the adults. In preterm neonates, the stratum corneum has only 2 to 3 layers. This deficiency and immaturity of the stratum corneum results in the increased fluid and heat loss, leading to electrolyte imbalance, reduced thermoregulation, and increased risk of infection. So, अभी इसमें क्या है कि सबसे जरूरी हमें ये मालूम होना चाहिए कि ये जो स्किन लेयर जो है ये थिन जो होती है उसकी वजह से हीट लॉस होता है. जनरली हम एवरीडे हमारे एनआईसी में देखते हैं कि हम रोज वेट चेक करते हैं बेबीज का, और वेट गेन बहुत जरूरी होता है. तो वेट लॉस कब होता है बेबी का? जो स्किन जो है बेबी का जो बहुत थिन होता है उसकी वजह से कैलोरिक लॉस होता है, हीट लॉस होता है, उसकी वजह से वेट लॉस होता है. इसलिए स्किन का हमें ये करवाना बहुत जरूरी है, केयर लेना बहुत जरूरी है. सो व्हाट शुड बी आवर एम? Our aim should be to maintain the skin integrity and minimize the heat loss in the neonates. This is achieved by understanding the key difference of preterm and term neonate skin, enabling appropriate assessment and management of our neonatal population using enhanced evidence-based practice. So, what are different terminologies? Terminologies first is atopy. Atopy means just like an allergy. Family history of eczema, asthma, or allergic rhinitis, we can see atopy. Then we have just seen stratum corneum, which is the outermost layer of the epidermis. Then we have to maintain the pH of the skin, which represents the acidity or alkalinity of the solution in a logarithmic scale, where 7 is a neutral. Then what is Wernicke's gaseosa? It's a waxy white substance on the newborn skin, and these are the different layers of the skin: dermis, epidermis, dermis, and hypodermis. So we can see this in this figure, that this is striatum corneum. This is the thinnermost and outermost layer of the skin, and this is very thin in neonates and preterm. So that's why there is more heat loss there. So while taking care in a new NICU, what care we should take? हमें क्या क्या केयर लेना चाहिए? जब अभी हम एज अ नर्स रेगुलर जब राउंड को आते हैं, सुबह में ड्यूटी को आते हैं, तो हमें क्या देखना चाहिए, ये हम अभी थोड़ा सा प्रैक्टिकल ही देखेंगे। तो जब वेरी लो बर्थ वेट बेबीज होती है, जिनका वेट 1500 ग्राम से नीचे होता है, तो जब हम उनको देखते हैं एवरीडे, तो हमारे जो एवरीडे हमें क्या देखना चाहिए? तो द कलर ऑफ द स्किन हमें देखना चाहिए कि बेबी के स्किन का कलर कैसा है, कोई रैश है क्या, इज एनी रैश देयर, इज एनी ब्रेकडाउन देयर, इज एनी देयर प्रेशर सोर्स है क्या वहां पे, जिसे हम बेड सोर बोलते हैं, वो है क्या? और फिर मॉनिटर प्रोब्स भी हमें देखना चाहिए कि मॉनिटर प्रोब्स अच्छे से लगाए है कि नहीं, और आईवी साइट्स जो हमने लगाई होती है वो भी हमें देखना चाहिए। So generally we do not bath them, and we do not apply any emollient or cream to them, and we should provide appropriate bedding and support using soft bedding. So we should use soft bedding to them. हमें उनका जो बेड बनाते टाइम एक्स्ट्रा केयर लेना चाहिए। एंड कोई भी सिक इन्फेंट रहेगा, कोई वेंटिलेटर इन्फेंट है या सिक है, वेरी लो बर्थ वेरी है, तो उसको एवरी 3 to 4 आवर्स ही हमें उसका पोजीशन चेंज करना है। एंड टर्न इन्फेंट विद द स्किन ब्रेकडाउन विथ एवरी 2 आवर्स, ये हमें उसका केयर लेना ही है। यहाँ पे मैंने एक आपको इमेज दिया है, इस इमेज में हम देख सकते हैं कि व्हाइल फिक्सिंग ईटी ट्यूब, हमें हमेशा वी शुड अप्लाई टेगाडर्म ऑन द स्किन बिफोर पुटिंग एनी डायनाप्लास्ट और एनीथिंग। सो ये हमें करना चाहिए। अभी जब हम आईवी कैनुला लगाते हैं, आईवी कैनुला लगाते टाइम भी हमें केयर लेना चाहिए कि हमें वहां पे पहले स्पिरिट अप्लाई करना है, फिर क्लोरहेक्सिडिन अप्लाई करना है, फिर से स्पिरिट से साफ करना है, फिर आईवी कैनुला लगाने के बाद वो पूरी साइड जो है वो हमें फिर से स्टेराइल वाटर से साफ कर लेना है। कोई भी हम अगर टेप लगाते हैं, व्हेन वी अप्लाई एनी टेप ऑन वन स्किन, then we should apply it in a minimal possible area of the skin. जितना जरूरी है सिर्फ उतना ही लगाना है। ओके और कैसा है कि ये जब हमें लगाना है तो हमें निकालना भी है, और निकालते टाइम जब उसको इरिटेशन होता है स्किन को, तो बेबी को इट्स वेरी हॉरिबल पेन। सो दैट्स व्हाई व्हाइल पुटिंग द टेप वी शुड मिनिमाइज द एरिया। सेकेंडली once applied we should put it at least for 24 hours. अगर कोई टेप हम लगाते हैं तो उसको 24 आवर्स के पहले हमें नहीं निकालना है, ठीक है। देन वी जनरली डू नॉट बैंडेज आफ्टर वेनिपंक्चर। कोई भी सैंपल, ब्लड सैंपल हम रेगुलरली एनआईसी से लेते हैं, तो उसके बाद में हम वहां पे एक बैंडेज लगा देते हैं। तो जनरली इट इज नॉट एडवाइजेबल। व्हाट इज एडवाइजेबल, यू जस्ट पुट अ कॉटन स्वैब ऑन इट, जस्ट प्रेस इट फॉर फ्यू मिनट्स एंड देन रिमूव इट। ओके जब ब्लीडिंग रुक जाएगी तो अपने आप आपको अलग से वहां पे बैंडेज लगाने की जरूरत नहीं पड़ेगी। जब बैंडेज लगाने की जरूरत नहीं पड़ेगी तो टेप निकालते टाइम भी कोई प्रॉब्लम नहीं आएगा। तो ये केयर हमें जनरली लगाना है। और अवॉइड एनी बॉन्डिंग एजेंट, जस्ट लाइक अ टिंचर, बेंजोइन, और जो भी हम बॉन्डिंग एजेंट है ये हमें नहीं यूज करना है until unless it is extremely needed, तब तक हमें यूज नहीं करना है। तो अभी हम आज देख रहे हैं कि एनआईसीयू में हमारी सब सिस्टर्स ये यहाँ पे जो अटेंड कर रही है, तो उनको मैं इतना ही बस कहना चाहूंगा कि इट्स वेरी डेलिकेट स्किन, सो वी शुड टेक मैक्सिमम प्रिकॉशन व्हाइल अप्लाइंग एनी बैंडेज और एनी टेप और व्हाइल डूइंग एनी प्रोसीजर। तो हमें ये सब केयर लेना। जैसे हम कैट लगाते हैं, तो कैट लगाते टाइम भी मिनिमम अटेम्प्ट्स में हमारा कैट लग जाए, ये हमें केयर लेना चाहिए। अभी असेसमेंट कैसा करना चाहिए हमें, ये जो करना है, तो एवरी 3 to 4 आवरली हमें इसका असेसमेंट करना चाहिए। एंड ये जो है जिनको लॉन्गर स्टे को लगता है उनके लिए हमें एवरी 4 आवरली असेसमेंट करना चाहिए। सो इसमें एक इंटरनेशनल नियोनेटल स्किन कंडीशन स्कोर भी दिया गया है, इट्स कॉल्ड एज अ नियोनेटल स्किन कंडीशन स्कोर। तो जब हम असेस करते हैं रोज मॉर्निंग में बेबी का स्किन, सो व्हाट हमको क्या देखना चाहिए बेसिकली, वेदर बेबी स्किन ड्राइनेस है कि नहीं, एरिथेमा है क्या, एनी ब्रेकडाउन है क्या, ये हमें सब देखना चाहिए। उसका ये स्कोर यहाँ पे दिया हुआ है। इसका सिग्निफिकेंस ये है कि ये तीनों का स्कोर अगर मिला के हमें 6 से ज्यादा आ जाए तो हमें इमीडिएट उसका एक्शन लेना है। तो न्यूरोनेटोलॉजिस्ट को हमें इमीडिएट ये बोलना है कि ऐसा हमें लग रहा है। सो क्या क्या देखना है, ड्राइनेस, वेदर स्किन इज ड्राई और नॉट, और वेदर देयर इज वेरी ड्राई और नॉट। मीन्स आपको देखते ही समझ में आता है जब आप रोज राउंड लेते हैं कि बेबी का स्किन कल कैसे था, आज कैसा है। इज देयर एनी इरिथेमा, एनी रैश है क्या कोई बेबी के बॉडी पे, ये हमें देखना है। एनी स्किन ब्रेकडाउन है क्या वहां पे, कोई लेकिन लोकलाइज्ड एरिया में ब्रेकडाउन है क्या, ये हमें मस्ट है देखना। तो यहाँ पे नीचे वही दिया कि इंटरप्रिटेशन कैसा करना है। द रिलेवेंट मेडिकल टीम मस्ट बी नोटिफाइड if a neonate scores a single score of a 3 in one area or a combined score of a 6 and above। तो ये हमें वहां पे असेसमेंट करना है, ठीक है। अभी कुछ कॉमन चीजें हम देखेंगे जो हमें एनआईसीयू में देखने को मिलती है। जैसे फर्स्ट थिंग इज एक्स्ट्रावेसेशन इंजुरीज। अभी क्या है ना कि व्हाट इज एक्स्ट्रावेसेशन इंजुरीज, यहाँ से हम थोड़ा सा शॉर्ट में बोलूंगा, थोड़ा सा टाइम की कमी होने की वजह से। व्हाट इज एक्स्ट्रावेसेशन इंजुरीज? It is an infiltration of IV administered solution into the subcutaneous tissue and is common side effect in NICU. It may result in a complete skin loss, infection, nerve and tendon damage. It may cause potential risk of a cosmetic and functional impairment. Parenteral alignments, fluids, calcium, potassium, sodium bicarb solutions, ये जो है vasopressor agents, antibiotics, these are different solutions which can cause these extravasation injuries. तो इसमें क्या करना है कि हमें जहां पे भी आईवी साइट हमने लगाई है रोज देखना है कि वहां पे कोई स्वेलिंग तो है नहीं, आईवी अच्छे से जा रहा है क्या, आईवी पॉइंट के आजू बाजू में कोई स्वेलिंग अगर दिख रही है तो इमीडिएट हमें नियोनेटोलॉजिस्ट या जो भी हमारे रेसिडेंट डॉक्टर्स है हमें उनको ये बोलना है। सेकेंड थिंग कि अभी इमीडिएट जब तक हमारे डॉक्टर्स या कोई हमें जब तक मिलते नहीं है तब तक इमीडिएट आप क्या कर सकते हो, आपकी जगह पे आप एक चीज कर सकते हो, स्टॉप आईवी इन्फ्यूजन प्रॉम्प्टली एंड रिमूव बैंड्स दैट मे एक्ट एज अ टॉर्निकेट। सेकेंड, जहां पे आपको स्वेलिंग लग रहा है, जिस भी पार्ट को हमने कैथ लगाया है या जहां से हम जा रहे हैं वहां पे स्वेलिंग लग रहा है, उसको एलिवेट करना है। तो एलिवेट करके वहां पे स्वेलिंग एडिमा जो है वो कम होने का कम होता जाएगा, ठीक है। जहां पे भी आपको लग रहा है कि अभी यहाँ पे थोड़ा सा स्वेलिंग है यार, वहां पे वूंड हो रहा है, तो वहां पे यू हैव टू डू अ वूंड ड्रेसिंग एंड ड्रेसिंग चेंजेस कैन बी पेनफुल, सो कंसीडर यूजिंग comfort measures like sucrose and different analgesics as needed. Then when we have to irrigate wound, then irrigate wound with sterile saline to remove any exudate or any debris. Okay, and topical agents like mupirocin or bacitracin can be used if wound is infected. Okay, so हमें ये चीज ध्यान रखना है कि हमें कोई एक्स्ट्रावेसेशन इंजुरी रहेगी तो वो इमीडिएट अर्ली डायग्नोसिस उसका होना चाहिए। तो ये हमारा अगर रेगुलर राउंड है, हम अगर अच्छे से रोज देख रहे हैं तो हमें ये इमीडिएट आइडेंटिफाई हो जाता है। देन अनदर कॉमनेस्ट थिंग वी सी इन आवर एनआईसीयू इज नैप्पी केयर। तो पेरिनियल डर्माटाइटिस जिसे हम बोलते हैं कि जिससे बार बार हम जैसे अभी नैपी चेंज करते हैं, तो व्हाट शुड बी द एग्जैक्ट टाइमिंग, एटलीस्ट 4 आवर्स, एवरी 4 आवर्स हमें उसको चेंज करना चाहिए। हमें रोज नैपीज को देखना चाहिए कि नैपी एरिया कैसा है, रेड है क्या, वहां पे कोई इरिटेशन है क्या। तो the perineal environment is prone to change in the skin barrier, causing skin irritation, increased moisture and prolonged contact with the irritants, and alkaline skin surface may contribute to the dermatitis. So nappy changes should occur at regular intervals where clinically is appropriate to avoid irritation to the perineal skin environment. Evaluation of the perineal area is required at each nappy changes to ensure early identification of perineal dermatitis and candida infections. सो अभी हमें यहाँ पे देखना है कि वहां पे जब मॉइस्चर रहेगा तो वहां पे कैंडिडा इन्फेक्शन भी हो सकता है, फंगल इन्फेक्शन भी हो सकता है, और वो हमें प्रिवेंट करना है तो हमें अर्ली आइडेंटिफिकेशन करना बहुत जरूरी है। सो वी ऑलवेज यूज डिस्पोजेबल नैपकिन्स, एंड जब हमें पॉटी का या कुछ साफ करना होता है तो ऑलवेज यूज कॉटन बॉल्स और सॉफ्ट डिस्पोजेबल टॉवल्स विथ वार्म वाटर एट द प्रेफर्ड क्लींसिंग मेथड, राइट। हमें जब साफ करते टाइम कॉटन बॉल्स, प्लेन कॉटन बॉल्स स्टेराइल वाटर में उसको लेके उसको साफ करना है एकदम आराम से, अच्छे से, कोई इरिटेशन ना हो जाए वहां पे। और पीएच न्यूट्रल क्लींसर में बी यूज्ड इफ स्टूल इज ड्राई एंड डिफिकल्ट टू रिमूव। apply protective ointments containing zinc oxide every time uh, when you cleanse the area. Wipes should be avoided. Of course, wipes should be avoided because it may contain alcohol and any irritant. Any barrier cream should be used in all neonates at a risk of a perennial dermatitis at every nappy change, at the first sign of erythema or a skin breakdown. आपको कभी भी ऐसा लगे कि वहां पे इरिटेशन हो रहा है या आपको ऐसा लग रहा है कि वहां पे डर्माटाइटिस लाया, अर्ली फंगल इन्फेक्शन जैसे लग रहा है, तो आपको इमीडिएटली वहां पे स्किन बैरियर क्रीम लगानी है, जैसे जो आपको अपने एनएफयू में वो अवेलेबल होती है, तो वो हमें लगानी है। अभी क्या होता है ना, हर बार हम क्या करते हैं कि एवरी टाइम जब हम चेंज करते हैं तो हम करते हुए बैरियर क्रीम भी निकालने का प्रयास करते हैं। तो इट्स नॉट नेसेसरी कि वो क्रीम हम एवरी टाइम निकालें until वहां पे कोई सॉइल विद स्टूल और एनीथिंग। अदरवाइज वी हैव टू पुट इट लाइक दैट कि यहीं पे वहां बोला गया है कि बैरियर क्रीम शुड बी यूज्ड इन ऑल यूनिट्स एट रिस्क ऑफ पेरिनियल dermatitis, and removal of the barrier creams between the nappy changes is not necessary. Rather, apply another layer and layer of barrier creams containing plant extract and fragrance should be avoided. मींस कोई भी अगर क्रीम है जिसमें बहुत ज्यादा फ्रेग्रेंस है तो वैसी क्रीम हम जनरली एमआर एनएफसी में नहीं यूज करते हैं, तो वो जो क्रीम है वो निकालने की जरूरत नहीं होती है। Risk factors for the perennial dermatitis include frequent stooling, antibiotic usage, malabsorption, opiate withdrawals and abnormal rectal sphincter tone. तो इसकी वजह से हमें ये केयर लेना चाहिए। Another thing what we have to take care of is आई केयर। तो हमें रेगुलर आई चेकअप करना चाहिए बेबीज का। आई चेकअप करना है यानी क्या है, एवरीडे हम जब बेबीज की आईज देखते हैं तो थोड़ा सा एक्सुडेट यानी थोड़ा सा वाटरी डिस्चार्ज आता ही है हर बेबीज को, इट्स नॉर्मल। बट व्हेन इट इज एबनॉर्मल, व्हेन इट इज पुरुलेंट, वहां से पस जैसा आपको ये येलोइश पुरुलेंट डिस्चार्ज अगर दिखे तो इट इज एबनॉर्मल। ऐसे टाइम पे जनरली हम क्या करते हैं, कॉटन बॉल लेना है और उसको इनवर्ड से आउटवर्ड की तरफ आई साफ करना है एवरीडे। अगर आपको ऐसा लग रहा है कि एक्सुडेट है तो आपको प्लेन सलाइन कॉटन लेना है और उसको सलाइन से जो है NaCl अपना 0.9% होता है, उससे आंखें ऐसे अच्छे से साफ करके लेनी है। अगर आपको ऐसा लग रहा है कि देयर इज डिस्चार्ज, देयर इज येलोइश डिस्चार्ज देयर, देन व्हाट वी शुड यूज सम आई ड्रॉप्स विथ ऑफ कोर्स एडवाइस ऑफ आवर रेसिडेंट डॉक्टर्स और नियोनेटोलॉजिस्ट। तो वही यहाँ पे हमने बोला है कि exudates from eyes can be common occurrence in the neonate. However, increase in the eye color may significantly an infection and such requires medical review. The neonate with reduced functioning of eyelids, जैसे कोई preterm neonate रहेगा, कोई serrated रहेगा, तो उसको हमें रेगुलर रूटीन आई केयर करना है और उसको आईज को लुब्रिकेशन जो है वो जरूरी है, तो लुब्रिकेंट्स उसको ऐड करना है। Minimum 4 hourly cleaning of an eye with 0.9% NaCl from inner corner to outwards with a sterile cotton ball. Application of a lubricant in ointment, ointment ये भी हमें करना है और monitor for any sign of infection or abrasion, ये हमें देखना है। अभी वैसे ही हमें, जैसे हम आईज का केयर लेते हैं वैसे हमें ओरल केयर लेना है। तो रूटीन ओरल केयर ऐसा हमें ज्यादा यूनिट्स में करने का ज्यादा जरूरत नहीं पड़ता है, जैसे आप देखते हो। बट जो इंटुबेटेड चाइल्ड है, यानी चाइल्ड विच इज इंटुबेटेड, तो उसको हमें रूटीन ओरल केयर करना चाहिए। सो द रूटीन असेसमेंट शुड बी यूटिलाइज्ड टू आइडेंटिफाई एबनॉर्मलिटीज. What are the neonates requiring regular oropharyngeal suctions, intubation, or other oral supportive devices will require regular checkup to reduce the injury to the lips and oral mucosa. So what care we should take? हमें क्या क्या केयर लेना चाहिए? तो minimum 4 hourly cleaning of lips with sterile water for injection to ensuring not to pull away any skin that may यानी वहां पे कोई स्किन ब्रेकडाउन है या वहां पे कोई स्किन ब्रेक है, वो हमें देखना है। अदरवाइज जो एक्सप्रेस ब्रेस्ट मिल्क होता है, कॉमन प्रैक्टिस हमारे एनएफसी में हम करते हैं कि अगर आपको ऐसा लगे कि लिप्स आर ड्राई और थोड़ा सा उसको क्रैक्स लग रहा है आपको, या बेबीज को एटोपिक डर्माटाइटिस जैसा कुछ है या स्किन ब्रेकडाउन है, तो व्हाट कॉमनली वी कैन यूज इट, एक्सप्रेस ब्रेस्ट मिल्क जो होता है एक्सप्रेस, उसको कॉटन बॉल्स पे लेके हल्के से लिप्स पे से अगर हम घुमाएंगे तो इट एक्ट्स एज अ वंडरफुल इमोलिएंट। मींस अदर कुछ इमोलिएंट हमको लगाने की जरूरत नहीं है, तो ये केयर हमको लेना चाहिए। बाकी इसमें और ओरल केयर में कोई ओरल कैंडिडियासिस है क्या, अंदर कोई मुंह में अंदर इन्फेक्शन है क्या, ये भी हमें रेगुलर देखना चाहिए, क्योंकि रेगुलर हम जब इंट्यूबेशन करते हैं या रेगुलर वैसे कोई बच्चों की केयर लेते हैं तो हमको ये देखना चाहिए ओरल कैविटी को कि अंदर कोई सफेद लेयर, व्हाइट लेयर जो है, जो ऐसा कुछ आएगा ओरल कैंडिडियासिस, वो कभी कभी कुछ कुछ बच्चों को हो सकता है, तो वो हमें देखना है। Then bathing, yes, of course, this is somehow controversial कि हमें बात करना चाहिए कि नहीं है। तो जैसे कोई सिक इन्फेंट रहेगा या वेरी लो बर्थ वेट इन्फेंट है, तो हम उसको तो वैसे तो बात करते ही नहीं, जनरली हम उसको स्पंज करते हैं, तो एवरीडे मॉर्निंग हम उसको स्पंज करते हैं। तो रेगुलर हमारे स्पंज प्रैक्टिस जो है, इसमें सिर्फ 2-3 चीजें हमें ध्यान रखना है। फर्स्ट थिंग इज दैट कि वी हैव टू मेंटेन द टेम्परेचर व्हाइल डूइंग, हमें थर्मोरेगुलेशन वहां पे रखना चाहिए। सेकंड थिंग कि मिनिमम टाइम में ये सब हमें करना है, स्पंजिंग भी करना है तो मिनिमम टाइम में हमें करना है, और इमीडिएट उसको रैप करके लेना है। यानी क्या होता है बहुत बार कि हम करते हैं एक बेबीज को, फिर उसका थोड़ा सा नॉट मोर देन 5 मिनट, 5 मिनट से ज्यादा हमें उसको ज्यादा टाइम नहीं लगाना चाहिए। और वही इसमें भी है कि डिफरेंट डिफरेंट हमें ये करना, क्या क्या केयर लेना चाहिए, यही स्लाइड में मैंने दिया था। तो ये शॉर्ट में मैंने आपको इसलिए बोल दिया क्योंकि इतना डिटेल में जाने के लिए अभी हमारे पास उतना वक्त नहीं है। फर्स्ट बात के बारे में ऐसे ही है कि जनरली फर्स्ट बात जो है हम जनरली किसको देते हैं, फर्स्ट बात जब हम देते हैं वो जो HIV पॉजिटिव या HBV पॉजिटिव जो बेबीज हमारे एनआईसीयू में आते हैं, तो उनको है कि यस यू शुड गिव फर्स्ट बात इमीडिएट टू देम। फॉर द न्यूनेट्स born to HIV positive mother, the first bath should occur as early as possible. Of course वहां पे बेबीज की जनरल कंडीशंस कैसी है, बेबी कैसा है, वेदर बेबी सिक और व्हाट, वो सब हम देख के ही ये चीज करते हैं, तो इतना हमें केयर लेना है। सेकंड थिंग जो वर्निक्स है उसको मैक्सिमम हमें इंटैक्ट रखना है। जो व्हाइट लेयर होता है बेबीज के बॉडी पे, वो व्हाइट लेयर जितना हम इंटैक्ट रखेंगे उतना थर्मोरेगुलेशन के लिए बेबी के लिए अच्छा रहेगा। तो हमें क्या करना है, मिनिमम जो जो वर्निक्स जो है, जो जितना ज्यादा वहां पे हम रख सके वो हमें रखना है। एंड हमें अप्रोप्रिएट रिवार्मिंग मेजर्स जो है बाद में, स्किन टू स्किन कॉन्टैक्ट और वो टॉवेल में पैक करना वगैरह जो हमारा रेगुलर है, ये हम यूज कर सकते हैं। जनरली हम जो वाटर यूज करते हैं इट शुड बी स्टेराइल वाटर, एंड उसका टेम्परेचर जो है इट शुड बी बिटवीन 37 to 37.5 डिग्री सेल्सियस, एंड पीएच शुड बी न्यूट्रल। तो वो हमें देखना है, ठीक है। तो जनरली बात के बारे में इतना ही करना है। अभी रूटीन बातें जैसे कि हम वही करते हैं कि कोई हम जो पानी यूज करते हैं, जो वाटर हम यूज करते हैं, सो मैंने अभी जैसे बोला कि इट शुड बी पीएच उसका न्यूट्रल होना चाहिए, एंड उसको एकदम स्टेराइल वाटर से ही उसको हमें स्पंज करना है। और क्लींसर जो भी हम यूज कर रहे हैं वो शुड बी दे शुड बी मींस free from any irritants or fragrance or any essential oils or any other chemical. So ये हमें उसमें कुछ ऐड नहीं करना है, ठीक है। और जो भी न्यूनेट को है उसको बात किया स्पंज करने के बाद इमीडिएट कवर्ड विद टॉवेल और पैटेड ड्राई, एंड दे शुड बी पैटेड ड्राई, एंड इंश्योर ऑल स्किन फोल्ड्स आर ड्राइड थोरली। यानी हमें ये चेक करना है कि कुछ गीला तो नहीं रहा है, एवरीथिंग शुड बी ड्राइड प्रॉपरली। एंड इम्यूलेंट अगर कोई ड्राई स्किन वाला है, ब्रेकडाउन स्किन ब्रेकडाउन वाला है, या कोई एक्जिमा का पेशेंट है, या कोई एटोपिक डर्माटाइटिस वाला है, तो जैसे हमें एडवाइस किया होगा हमारे डॉक्टर्स ने, न्यूनेटोलॉजिस्ट ने कि इम्यूलेंट लगाना है, तभी हम वहां पे उस पर इम्यूलेंट लगाएंगे, अदरवाइज हम इम्यूलेंट नहीं लगाएंगे, ठीक है। सो जनरली इसमें अभी प्रीटर्म में हमें क्या क्या केयर लेना चाहिए, जो मैंने ऐसे बोला कि जनरली प्रीटर्म्स में 32 वीक्स से जो लेस होते हैं उनको तो हम कभी बात का नहीं करते, उनको स्पॉन्ज करते हैं, तो वही मिनिमम टाइम में करना चाहिए। और एवरी जनरली बहुत वेरी लो बर्थ वेट रहेगा तो 2 to 3 डेज में एक बार आप स्पॉन्ज भी उसे कर सकते हैं। वही उसमें आपको यू हैव टू यूज द वार्म स्टेराइल वाटर एंड यू हैव टू सी एनी स्किन ब्रेकडाउन। और जैसे कि व्हेन वी आर बाथिंग, the whole body of the neonate is exposed in front of us, so we can see is there any rash, or is there any skin breakdown, or is there any eczema or any early changes जो है वो है क्या, वो सब हमें इवेल्युएट करना है इमीडिएट टाइम में, बहुत कम से कम टाइम में ये हमें करना है। अभी सेकंड है कि स्किन केयर में टाइम हम जो एडेसिव यूज करते हैं, तो उसका भी हमें देखना है कि what the adhesive should be used. A number of measures can be undertaken to ensure the reduced incidences of skin trauma with the use of proper adhesive that cause least trauma while still which is still effective. दोनों हमें देखना है कि वो इफेक्टिव भी चाहिए और वो लीस्ट ट्रॉमा भी कॉज करे. तो कंसिडर प्रोटेक्टिंग द स्किन विद द सिलिकॉन बेस्ड स्किन प्रोटेक्टिव फिल्म्स. तो हमें सिलिकॉन बेस्ड जो स्किन प्रोटेक्टिव फिल्म्स है वही हमें यूज करना है. जो मैंने इसके पहले भी बोला कि टेप्स जो है, टेप्स हम जो यू शुड बी यूज बैक्ड विद कॉटन वूल. हम कोई भी अगर टेप यूज कर रहे हैं तो उसको लगाने से पहले उसके पहले वहां पे कॉटन लगाना है, सो दैट एट द टाइम ऑफ पुटिंग वहां पे कोई इरिटेशन भी नहीं होगा और रिमूविंग के टाइम भी वहां पे कोई इरिटेशन नहीं होगा. सो अवॉइड रिमूविंग और एनी एडेसिव्स एटलीस्ट फॉर 24 आवर्स आफ्टर एप्लीकेशन. मींस 24 घंटे के अंदर तो उसको नहीं निकालना है, ये हमें उसका ख्याल रखना है. Remove adhesives horizontally using warm water with soft paraffin. Yes, जब हम ये निकालना है तो उसको horizontally निकालना करना है, एकदम slowly without any हरी, कुछ भी गड़बड़ ना करते हुए आराम से उसे गीला कर करके निकालना है. So that babies को समझना नहीं. यानी हमारे एनआईसी की सिस्टर्स बोलती थी कि जब आप उसको कोई टेप लगा रहे हो तब जैसे उसे समझ में नहीं आता है, वैसे ही जब उसको आप टेप निकालते हो वैसे भी बेबी को समझ में नहीं आना चाहिए कि आपने टेप निकाला है. इतना केयरफुली और इतना स्मूथली हमें ये सब निकालना है. तो ये इतना केयर हमें एनी एडेसिव्स और ये करते टाइम.
Dr. Rahul, last 2 minutes.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. So these are some ECG dots and ETT strappings जो है ये भी हमें निकालते टाइम भी यही केयर लेना है, एकदम आराम से निकालना है इसमें. और हमें बाकी कुछ नहीं है. अभी डिसइंफेक्टेंट्स हम क्या यूज कर सकते हैं? डिसइंफेक्टेंट्स में हम जनरली जो है क्लोरहेक्सिडिन यूज करते हैं बेबीज में, विच इज वेरी सेफ. लेकिन कोई भी अगर हम जो क्लोरहेक्सिडिन लगाते हैं, लगाने के बाद जितना जरूरी उतना ही लगाना है. और जब हो गया लगाने के बाद उसके बाद में पूरा स्टेराइल वाटर से हमें वो अच्छे से साफ कर लेना है. ये हमें अच्छे से केयर लेना है. ठीक है. umbilical cord का भी केयर ऐसे लेना है. एवरी डे वी हैव टू लुक फॉर द umbilical cord, इज देयर एनी डिस्चार्ज और एनीथिंग, वो हमें देखना है. पर कॉर्ड क्लैंप जो है, जब डायपर लगाते हो तो कॉर्ड क्लैंप जो है वो उसके ऊपर होना चाहिए, फोल्ड जो है उसके नीचे आना चाहिए. सेकंड थिंग, वहां से कोई डिस्चार्ज आ रहा है कॉर्ड क्लैंप से या एनीथिंग विच इज इरिटेशन है, वहां पे आजू बाजू में स्वेलिंग है, ये हमें एवरी डे अम्बिलिकल कॉर्ड का केयर लेते टाइम देखना है. जनरली हम बिटाडिन पाउडर कॉर्ड क्लैंप पे एडवाइस करते हैं डालने को, तो वो वही हम यूज कर सकते हैं. ठीक है. देन emollients, of course, emollient we do not use it regularly in any preterm child. जब हमको ऐसा लगता है कि कोई स्किन ब्रेकडाउन है या एटोपिक डर्माटाइटिस है या एक्जिमा है, तो ये डॉक्टर के एडवाइस से ही कोई इमोलिएंट हमें एडवाइस करना है, अदर लगाना है, अदरवाइज हमें इमोलिएंट नहीं लगाना है. तो ये कुछ बेसिक जो चीजें थी, ट्राई टू कवर मोस्ट ऑफ द थिंग्स. अभी ये मैंने कुछ चीजें स्लाइड्स यहाँ पे डाली थी, ये हमारे सब्जेक्ट नहीं है एक्चुअली, बट हमारे नर्सेस सिस्टर्स लोगों को ये पता होना चाहिए कि व्हाट आर कॉमन रैशेस. सो दीज आर द कॉमन रैशेस. दिस इज एक्जिमा टॉक्सिकम नियोनेटरम. ये एक कॉमनेस्ट यहाँ पे देखा जाता है, इसको कोई ट्रीटमेंट की जरूरत नहीं होती है. सेकंड, दिस इज नियोनेटल मिलिया, तो ये भी कॉमन होता है, ये भी नियोनेटल में दिखेगा, तो इट्स कॉमन. ऑल्सो मिलेरिया जिसको हिट रैश, तो ये भी कॉमन होता है बच्चों में, इसको ज्यादा ट्रीटमेंट की जरूरत नहीं होता है, सेल्फ रिजॉल्विंग भी होता है. और दिस वी कॉल इट एज मिल्क स्पॉट्स, ये बच्चों में होता है, तो ये भी कॉमनली वी हैव सीन दिस इन नियोनेट्स. सो विथ ऑल दिस आई हैव ट्राइड टू कवर मैक्सिमम in such a small time, but I am really thankful to Maharashtra State NNF for this opportunity to give me talk on this great platform. Thank you so much you all. अगर आपको किसी को कोई क्वेश्चन रहेगा तो आप पूछ सकते हैं. I am done with sir. I am done.
Yes, Dr. Rahul, thank you so much for this information. Now, Dr. Nanavati ma'am, would you any expert comments from your side? Ma'am, can you hear me? Okay, till then we have Dr. Sagar Lad who has joined in. Yes, ma'am. Ma'am, any expert comments from your side regarding skincare? Nanavati madam?
the question in the chat box.
Yes.
Yeah, yes.
Yes, we can hear you now.
Yeah.
Any expert comments from your side regarding skincare of newborns?
So I think, Dr. Rahul has done a wonderful job and brought out, a lot of points which are important in the skincare. And the first and the most important thing that we have to consider skin, of course, we know that it is the largest organ in the body, and the skin, especially the small preterm babies, they will require significant care of, skin, because if you don't take care of skin, the baby is at a risk of infection. If the skin care is not taken, the baby is at the risk of hypothermia, and I think the nurses are the first one to take care of skin. And for that, he's told us a wonderful neonatal skin condition score. So if you make it a habit on your daily rounds, that you check, is the skin dry, is the skin broken, is the skin red, and you give special care for that, it will go a long way in the care of babies. And especially practically, you must use minimum adhesive. Even when you're fixing an RT, or say what, use minimum adhesive. Don't give it from one, or you're putting the skin probe, you're getting the pulse ox probe, see that the minimum adhesive is used. Also take care while removing it. And most important is that remember that when you remove an adhesive, it is painful for the baby. So it damages the skin, it causes pain for the baby, and it can affect the baby's subsequent neurodevelopmental outcome also if there are a lot of painful stimuli. So I think taking skin care, is the most important, and I think nurses are the pillars as far as the skin care of the baby is concerned. Also give, sort of attention when you are fixing the devices, say like a pulse ox probe, you are fixing, say endotracheal tube, you are fixing temperature probes, you are fixing so many other things on the baby's skin. You must take care that there is no excessive pressure and the baby, it's comfortable. So that has to be looked at. So I think even if we take a message and start looking at the baby's skin, it will go a long way. Thank you very much.
Thank you so much, ma'am. Thank you so much. Dr. Sagar Lad, thank you for joining in. Any comments from your side?
No, I think it was very lucid and excellent lecture given by Dr. Rahul, and he mentioned each and every point very nicely. So, because also skincare is important, there are things called as a dermal disaster, and sometimes it can be very much problematic and had a medical legal aspect also if the skincare is not properly taken. Sometimes if the intracath has tissued out and required some surgical intervention, it's very difficult to explain to the relatives about the condition. But I think the nurses are backbone of the neonatal ICU, and if the skincare is properly taken, such complication can be prevented.
Yes. Thank you so much. Thank you so much for those expert tips. So thank you, Dr. Rahul, for this excellent talk and presentation. Thank you very much for enlightening us about this skincare, which is such a critical and important topic in newborn care, because now small newborns are surviving, and the skin, which is the biggest organ of the body, which has to be taken more care nowadays, and we realize the importance of taking care of the skin as small tiny babies are surviving. Thank you so much for giving your time and coming for this lecture. Thank you so much.
Thank you, NNF Maharashtra. Thank you so much.
Dr. Sagar, can you invite the next speaker so that
next session is by, I would like to invite Sister Rekha Savan about the topic on the kangaroo mother care in the newborn. She is a senior staff in the neonatology since last 25 years and facility-based newborn care project coordinator since last 10 years. Over to you, sister.
Sister, we cannot hear you. I think you will have to unmute yourself. Can you unmute? And you can share your screen also if possible.
Is it audible?
Yes, now we can hear you.
Okay, just a second. is the slide visible and is she audible? Are we audible?
The voice is little bit low. We cannot hear you properly.
Okay, is it better now?
Yeah. We can see the slides. You can run the slideshow.
Yeah. Okay. Thank you.
So good afternoon, everybody. First of all, I would like to thanks to this organizing committee and Dr. Ruchi Nanavati that they have given me this opportunity. Today we are going to discuss about the kangaroo mother care. So kangaroo mother care, this is a special way to care for the low birth weight babies, less than the 2000 grams babies, for their health and well-being by promoting the effective thermal control, breastfeeding, infection prevention, and bounding. So kangaroo mother care is an effective way to meet the baby's needs for warmth,
It is
breastfeeding.
not moving. Slides are not moving, Meda.
Is it moving for you, ma'am, now? Because we're on third slide here.
I don't know. Ashish,
No, they are not. The slides are not moving.
slides are not moving.
So you, Kansham, can anything be done? Slides are not moving.
And you put it on a slideshow, Meda.
Slideshow.
It's on slideshow. I'll reshare it.
On slideshow. And this, now it is the third slide has come up now.
सर वो स्लाइड शो किया नहीं है अब तक वहाँ पे.
It's on slideshow right now. So we are on third slide now.
Can you change and check if the slide is moving?
Third slide.
Kangaroo mother care effective. Okay. So kangaroo mother care is an effective way to meet the baby's needs for warmth, breastfeeding, and protection from the infection with multimodal stimulation, safety, and love. So KMC satisfy all the 5 senses of the infant. Through infant feels that mother's warmth for the skin to skin contact, that is touch. Second, listen to her voice and heartbeats, that is hearing. Third is that baby sucks on the breast milk, that is taste. Fourth is that eye-to-eye contact with mother and baby, that is vision, and smell, odor, that is the olfaction. These all 5 senses are present and satisfied through the kangaroo mother care. So this kangaroo mother care has started in the South America at Colombia in Bogota in 1978 by Dr. Edgar Ray Sanbaria. In this hospital, nearly 33,000 deliveries occurs, and in that less under equipment, understaffed. Slides are moving, madam?
No, slides are not moving.
Yeah, slides are not moving. Maybe you can close it and restart again.
Okay, we'll do that.
Put it on a slideshow.
Now they are moving. Yeah.
Actually, they're not moving on slideshow. We will keep on this. So by this way, it will keep changing as well.
Okay. Yeah. Now we can see the third slide right now.
So this kangaroo mother care has started in the South America at Colombia in Bogota in 1978. Dr. Edgar Ray Sandaria has started this. In their hospital, nearly 33,000 delivery occurs annually, and so many death occurs because of the understaffs and under equipment. So he decided to give the natural warmth to the baby, and from that, that a kangaroo mother care has started. All of you know that you have seen that kangaroo animal, how he keeps his baby in his pouch for the feeding. He remove the baby, and again that baby goes in his pouch. Like that only, they have started the kangaroo mother care. In these slides, you have seen that nearly 27 million babies born in India per year, and out of that, so many death occurs in first day, first week, and first month of the life. So we have to improve our neonatal care. Now we have to see the problems of this low birth weight. Why low birth weight babies needs the kangaroo mother care? First is the most important, that the hypothermia. These low birth weight babies are having hypothermia, common problem. And due to this, if it has not taken care, then there are so many problems occurs. Why these babies are low birth weight babies are hypothermia? Because of the yes. Why these babies are having a hypothermia? Because these babies are having less brown fat, less brown subcutaneous tissues. Then babies are having a larger surface area. Compared to the surface area, baby's head is very large. Again, these babies are having extended posture. That's why this baby remains in hypothermia. Due to that hypothermia, so many problems occur. That is the hypoxia, hypoglycemia, apnea, poor weight gain, then infection. So many problems will be occur due to the low birth weight babies. Now we have whenever the baby is a low birth weight baby and admitted in NICU, it is very expensive. That family has to expend so many money. And again, that after doing everything, sometimes that outcome is also poor. So kangaroo mother care is a comprehensive low-cost method of the care of this stable low birth weight babies. That baby should be, whenever we want to keep the baby in kangaroo, that baby should be hemodynamically stable. That stable, it said that word is having meanings. S stand for the sugar. Baby should not be having hypoglycemia. T for the T stands for the temperature. Baby's hands and feet should be warm. Then A stands for the clear airway. Apnea, baby should not be should not be having apnea. B for the breathing, regular breathing, and BP. L stand for the laboratory reports, and E stand for the emotional support. Now benefits to after giving KMC, benefits. What are the benefits to the baby? Babies are having KMC decreases the hypothermia, hypoglycemia, apnea, and then decrease O2 requirement. Infection prevents infection and prevents pain also. Benefits to the mother. The mother is promotes the lactation, increase the rate and duration of the breastfeeding, then reduces maternal stress, and increases bonding between mother and baby. Now benefits to the family. KMC saves the money, money for as the baby discharge early. Then so father returns work earlier. Then these babies are a healthier baby and they are having the better IQ. Again, KMC saves money as a community base, because the babies are getting early discharge, reduces the healthcare cost as less equipment, then no expenses on the antibiotics, medicine, and again that baby miss early discharge. So Hospital stay is also decreases. So now what are the problems and benefits we have seen? Now main is that the components of the kangaroo mother care. The components of the kangaroo mother is skin to skin kangaroo position, skin to skin contact, extensive breastfeeding, and because of these causes the early discharge and the regular follow-up. So for the kangaroo position, criteria for the kangaroo baby, that baby should be should not be having any critical, baby should not be in critical condition. Then tolerating oral feeds, baby may be on IV fluids, that also that you can keep the baby in kangaroo. Good response to the stimuli, and KMC provided that mother is not available, then any caretaker is there, then you can keep the baby in kangaroo. For the sick neonates, also you can give kangaroo, but there should be a strict supervision and observation should be there. Otherwise, oxygen, if the baby is on CPAP, if baby is on getting oxygen or the IV fluids, you can keep the baby in kangaroo. So this is our KEM's designed kangaroo bag. In this picture, you have seen the how we prepare the baby. Cap, front open frock, nappy, and sock should be there. Then in these slides, you can see that how to hold the baby, that one hand has to under the neck and 4 fingers to the side. One that thumb should be at the another side, and one hand the support for the buttocks.
Sister, we cannot hear you. You have muted yourself.
Can you see a video playing right now?
The video cannot be seen.
Okay, 1 second. Is the video visible now? Yes.
Yes, we can see the picture, but it's not moving.
We will start the video.
Yeah.
Okay. So now we are starting for the positioning, skin to skin contact. That baby has well dressed with cap, front open frock, then nappy, and now we are keeping the baby in, giving the baby kangaroo. So preparation for the kangaroo, placing the baby in between the 2 breasts. This is now we keep the baby in kangaroo. Now we are going to keep the baby on the mother's chest. That is the skin to skin contact. Now baby is well prepared, well dressed. Now mother is also ready to take the baby in kangaroo. That mother is also having criteria that she has to take the bath. The front open gown should be there. No rings, no watch, no bangles, no chain. Nothing should be there. She has to take the bath. Okay. Now she is ready. The band is in the mother's neck. That baby is in between the in between 2 breasts in the upright position. Then baby both the hands on the mother's breast, legs are fold just like a frog position. Baby's head is turned to the one side. It is like slightly extended position. Not too much flexion, not too much extension, that baby can see and mother can see face. So that 2 bands, we tie the 2 bands at the side of the mother. See, these are 2 bands we tie at the side. so that baby mother is comfortable, that she don't have any worries that my baby will fall down from the kangaroo. Okay, so now baby is comfortable in kangaroo. Baby is awake and feeling satisfied and happy also. So this one cloth again we are tying on the both on the mother and baby, that baby and mother should be comfortable, but no any worry that my baby will fall down and all that. So this is the reclining chair. Mother is going to take rest in the chair. So now you have seen how we are keeping the baby in kangaroo. Whenever we are giving kangaroo to a baby, that baby should be observed, supervised by the staff nurses for the placement. Baby should be in upright position, not in horizontal position. Again, baby's breathing should be observed. That neck position also have to observe, not too much extended, not too much flexion. Flexion should be there, and baby's airway should be clear. Okay. Now, whenever we are keeping the baby in kangaroo, after going home or in the hospital also, mother can sleep very well with extra 2 pillows. At home, she can work, she can do each and everything, cooking, learn, look at TV, reading books, whatever she wants, she can do. Again, she can travel by in bus and trains, everywhere she can travel, keeping the baby in kangaroo. Whenever she has to sleep, she has to take the extra pillows. If mother is not available, then family members or the father has to keep the baby in kangaroo. Whenever male person is keeping in kangaroo, especially father, that is a KFC, that father and baby bounding will take place. And male's temperature is 1 degree centigrade than the female. So it is also benefited for to maintain the temperature. Now, second component is the exclusive breastfeeding. Okay, so for the breastfeeding, if the baby is on the gavach feeding, then mother can express the milk. If the baby is in kangaroo, still she can express the milk. For gavach feeding, no need to remove the baby from the kangaroo. You can give in a KMC position also. For the katori spoon feeding, only she has to remove that neck band from the baby, and she can give the palade feeding or the katori spoon feeding. For the breastfeeding, she has to lose that side band and hold the baby near the breast, so baby can suck easily, or turn the baby on whichever side she want to give the feed. So that is the second component of the exclusive breastfeeding. So now, due to this early discharge and regular, baby will be getting early discharge. Criteria for the discharge, that weight gain should be 15 to 20 grams per kg per day for 3 days. Feeding on the katori spoon feeding or the breastfeeding, baby should not be discharged on the gavach feeding. Maintain the temperature in room air. Then no evidence of illness. Baby should not be on the antibiotics or any medicine except the vitamins, calcium and all that. Now, whenever we start the KMC, it should be minimal handling should be there. It has to keep the baby for more than 2 hours and last for the 10 to 20 12 hours. If it is more than 20 hours, 24 more than 20 hours, then baby is benefited more. So now whenever we are giving discharge to the baby, we have to teach the mother, we have to give the knowledge. Again, before discharging, we decide the discharge that mother and family members should be having confidence that they can take care of the baby in kangaroo at home. And the nurse who is on duty, she also have to confidence that this mother can take care at home. So after that only we can discharge the baby. Now, while discharging the baby, we have to tell all the things to the mother about the danger signs, and then immunization of the baby, how to take care of the baby, not to give birth till 2,500 grams. Baby reaches to 2,500 grams. Then means before touching the baby, that she has to wash the hand. Everybody has to wash the hands. Hand hygiene has to take care. Then if anything happens about the danger signs, if anything happens, she has to bring the baby to the hospital at any time. So now we started that we decided that when to keep the baby in kangaroo, but we are nobody to decide that when to stop the kangaroo mother care, because whenever baby reaches to the 2.5 kg just at the gestational age, baby decides its own. That baby gives you cues that a baby will cry, and cries or fidgets when put in KMC. Whenever babies are coming to follow up OPD, means on third day, then 7 day or 15 days, we have to call the mother for the follow up of the baby. That very regular babies are coming for the follow up, then we can detect what if any babies are having problem, and we can take according to that. So regular follow up should be there. If they are not coming, then we have to contact on the phone or mobile, whatever is available, we have to call them. Whenever they are coming to the OPD, then that time we have to do the ultrasound, then ROP. Again, we have to check for the weight gain is there, or 15 to 20 grams per kg per day weight gain is there or not. Then we have to check for the length, whichever the 0.7 to 0.9 centimeter per week, it has to be increased. Head circumference also for in per week 0.7 to 0.9 centimeter has to increase. If it is more than that head circumference, then we have to think about any problems, or just like hydrocephalus and all that. So we can treat early to for these babies. Then again, we have, whenever mothers are coming, which feed they are giving, breastfeeding or what, top feeding, what they are giving, how they are giving, what they are using, how to take care, everything we have to ask them, and we have to give the health talk to the mother. So this is our kangaroo center, follow-up center, whichever babies are coming for the follow-up. So in this KMC center, here we are following our babies after discharge. It is our responsibility for the doctor and nurses to give the KMC for to overweight babies to and improve their survival and well-being. Thank you.
Thank you so much, Sister Rekha. Any Nanavati madam, any comments on kangaroo mother care?
Yeah, Rekha, will you stop sharing?
Yes, madam.
Yeah. So thank you, Rekha. That was really a nice presentation, and the video was very excellent. And I think that has really given everyone the idea that how do we actually start kangaroo mother care for the babies, right? Now the kangaroo mother care is something beautiful for the child because it satisfies all 5 primary senses of the babies, and that's why it is something good for the baby's growth and well-being. Now we know that kangaroo mother care is good, but studies show us that the world over the application of kangaroo mother care is even less than 5%. So it is the duty of all of us to pass on these benefits of kangaroo mother care to the babies. We should get all this knowledge what we have, that should get translated into the practice. So that is the the requirement of the time to initiate and to sustain kangaroo mother care in your unit. And if you are already doing kangaroo mother care, then you must increase the duration of kangaroo mother care, what you are giving to the babies. If you are doing it if the mother is doing it for 4 hours, motivate her to doing it for 6 hours, 8 hours, and finally your aim is to give almost 24 hours a day. So that is as far as the
This is a checklist.
the second important thing what I want to convey is that kangaroo mother care is not for, it's not a poor man choice. The kangaroo mother care is required in each and every institution, whether it's a public hospital or where you have a corporate setup. So, kangaroo mother care, giving kangaroo mother care is a standard of care, and not providing kangaroo mother care is ethically not right. So, all of us should try to give kangaroo mother care, right? Now, Rekha has told you everything in detail. I just want to say one or two new concepts in kangaroo mother care. And that is, first is what is called as an early KMC or immediate KMC. So what have we learned so far? That we start kangaroo mother care after the baby is stabilized. So that happens after first few days. But now the science has shown us that if you start kangaroo mother care immediately after birth, this thing in the labor ward itself, the babies have better outcomes. Okay, these are the studies which are done world over, and the Safdarjung Hospital from India was a center, and they had kept the mothers, the mother's cot and the baby's bed next to each other, and the mother used to provide kangaroo mother care to the babies, and they have shown, that this is practical, feasible, safe when you start kangaroo mother care immediately after birth. So this is called as EKMC, or it is called as IKMC. Now, application of this IKMC in all the centers will require a lot of, changes in your existing infrastructure and everything. But we should be aware that we should be giving kangaroo mother care as soon as possible to the baby, because it is in the best interest of the baby. Because today we know that we should not be separating mother and baby. The maximum stress or the toxic stress what the baby gets and also mother is the separation of mother and baby. So when you put the baby in kangaroo mother care, it brings back the mother and baby, and that is the stress of separation becomes less, and that's why there is the importance of EKMC or IKMC. And the second important thing is what is called as CIKMC, that is community initiated KMC. Sometimes it happens that that the KMCs, most of the times it is initiated in the hospital, should be, and then it is sustained in the community. But at times, there are times where it is not initiated in the hospital. One can initiate kangaroo mother care in the community, and that again has shown to be, have a longer effect basically for the, successful implementation of KMC. So that is called as community initiated KMC. And also there are, sometimes rather than keeping the baby vertical, one can keep the baby slightly diagonal. Rather than keeping the baby like this vertical, one can keep the baby little diagonal. So when the baby actually looks at the mother and it is shown to be, like sort of satisfying both the babies and mothers, there is better bonding, there is more psychosocial attachment between mother and baby. So just little bit turning of the baby's position, and that is going to be good for the child. So these are, something newer things which are coming into KMC. So I think all of us, after this are convinced that kangaroo mother care is the most important for the baby. And I, sort of request you to try your best to initiate this KMC at your institution. At our institution, I think we have done at least probably more than 150 to 200 programs in kangaroo mother care. And we have trained, the people from all over India in kangaroo mother care. And the main person in the training was, Rekha. So if you have any questions, you require any help, you require any material, you require anything, you are most welcome to contact us, and we will try to help you out. Thank you very much.
Thank you so much, ma'am. I know we are really glad that you have contributed so much to kangaroo mother care training and the kangaroo mother care program. Dr. Sagarlal, any comments from your side? I think he has logged out. I think he has logged out. So just I would like to thank Dr. Ruchi Nanavati madam for gracing this program and giving a valuable comments about kangaroo mother care as well as the skin care of newborn. So I thank you both the speakers, Dr. Rahul Kulkarni as well as Sister Rekha Samant, for excellent presentation on kangaroo mother care and explaining in detail about the technique and the benefits about kangaroo mother care. So now I'd just like to inform everyone about the next continuing nursing education program, which will be held on the 24th of June. So we again are going to discuss about lactation counseling, and we are also going to look at pain management in newborn from nursing perspective. So I hope you all spread the word and more nurses get benefited from this educational program. And so we'll continue this nursing academics for the entire year. So thank you very much. Thank you all the viewers for joining in and listening to both the speakers so well. Thank you so much. So with this, I would like to close the session. Thank you all.
Yeah, thank you, Ashish.
Thank you, ma'am.
Thank you.